Okay, chapter 46, we're going to go through nephrolithiasis, nephrosclerosis, polycystic kidney disease, and we'll talk about obstruction of the kidneys and ureter in general. So when we're talking about obstruction, we're talking about any type of precipitant that is formed, and it could be of several different types, but it's formed somewhere in our renal system, either in the kidneys or in one of the junctions or in the ureter or in the bladder. So a lot of this has to do with where it's actually located at and what's the obstruction's composition. So there's several factors we have to take into consideration. But bottom line, obstruction is bad, obviously. So some things we can just pass. Other things, as far as kidney stones go, the larger they are, of course, the more impassable they are. But we'll go through that. So obstruction. Obstruction in some type of our renal system is going to cause a backflow of urine. Now, depending on how bad that obstruction is going to determine how bad your backflow is. So anytime we have backflow in the renal system, it could go from the bladder to the ureters, from the ureters to the kidneys. It could not even leave the kidneys, or it could be partially obstructed. And it could be completely asymptomatic. So it can go from being very severe to only being a asymptomatic issue that will resolve on its own. And again, it all depends on how large is it, how long has it been going on, what's the cause of it, what's it made out of, things of that nature. Okay, so hypoureter is basically just a dilation, and distension of the ureter. All right, so hypoureter is just the dilation and distension of the ureter itself, and again, that's caused because of an obstruction. The same thing, or the same prefix can be applied to nephro, so it'd be nephro, and again, same concept. Now we have a dilation of the renal pelvises, a dilation or an enlargement. So it's dilation or enlargement. Now, as we have obstructions, we're going to have issues where we can't pass urine, or we're trying to push urine through under a smaller constraint, which means that the muscles, the smooth muscles that help with that, are going to increase in size. Depending on how big that stone is or that obstruction is, either it might just slightly increase those muscles, or it will go to such an extent where the smooth muscles have become so enlarged that eventually they just give out, and then you don't have any urine formation at all. So again, it goes back to what it's made out of in the actual obstruction. I feel like we've probably hit on this, but I'll say it again. Vesco-uretal backflow. So basically all this is this is where I started, this is where I'm going. Yep, I know it's going like this. And this is where I ended. I remember writing it. So vesicle refers to the bladder here, and then so it's going from bladder to ureter, which is obviously not the correct direction, and that creates issues. But it can be ureter kidney or whatever. Basically, this is where it starts, this is where it's going, and this is where it ends. All right, so when you see something like that, that's the order it's going in. Okay, and it's obviously backwards. So obstruction, any type of obstruction, big, small, all depends on the precipitant and where it's located at. Generally, it's going to get stuck in your smaller places, your junctions, and you have two different junctions that you can think of, or two main areas that something would get trapped in. You've got your ureter junction, so you have a UVJ and a vesicle junction, and ureter. Well, bottom line, you have two junctions here, one right here, one right here, and basically it's where your renal pelvis is attached to your ureter, and where your ureter attaches to your bladder. So those are the two places where you'll generally have stone occlusion, or where they get stuck at. The first one being the smallest one is going to be between those renal pelvises and the ureter. So that's the first one that you would have something obstructed. Okay, so nephrosclerosis is kidney stone formation, and then Lithiasis is the formation itself, so nephrolithiasis is a formation of kidney stones. Kidney stones are most predominantly in men, and most predominantly in white men. Usually 20 to 50 years of age. It does happen in women, but usually it's associated with UTIs, which we get more of. So that's one of the risk factors there. Also, you have genetics, and genetics is going to play a role here, especially as we get into some of your nephro issues. But nephro issues. But there's some genetics to play a role in here as well. So men, white, 20 to 50 years of age, and genetic factors, or if they have a history of UTIs. So those are something that you have to think about. But bottom line, think about precipitation here. Anything that produces precipitation. And what is precipitation? It's the formation of or excess solute in the urine, and it's what the problem is that it's forming into a solid mass. So that's what we're talking about. All right, what are other risk factors? Of course, if you have low hydration, high sodium intake, also high calcium intake, and again, this depends on what the actual stone is made out of, but low hydrogen, low hydration, high sodium, high calcium, high uric acid. Uric acid is another stone precipitant, and so high uric acid usually associated with gout. Again, history of UTIs, genetic issues. Oh, hot climates. So if you're, in Florida, then you're probably going to be more at risk for kidney stone formation. And that has to do with hydration of the body, though. Sedentary. So people that are immobile are going to have a buildup of calcium. And the reason why is because your body tells you, hey, we don't need this much bone, and it starts to break it down. So that increases your calcium by being immobile or by being sedentary. High increase of protein. I always forget that. But if you remember, uric acid, protein, and high oxide, and those are, high oxide. So, and high purines. Purines are usually coming from your meats. Oxides are pretty much your green roughage, spinach, cabbage, things like that. Also in chocolate. But those are all things that attribute to stone formation. Oh, alkaline urine. That's the other one I missed. Alkaline urine. Okay, basically the acidity in urine, which if you remind, pH is generally 6. Besides it being beneficial for the antimicrobial factor, if it's not acidic enough, then you will have precipitants, because some of those insoluble things, calcium, things of that nature, they need that acidic environment to be able to be broken down. And when they can't be broken down, well, then that's when you have stone formation. So if you have alkaline urine, i.e. we're not acidic enough in our urine, you can't have that breakdown. So that's why that's an issue as well. All right, so how does this manifest itself? When you have kidney stones, first of all, they, again, it depends on the size, location, duration, all types of other stuff. But it's going to range from asymptomatic to like extremely excruciating. If that gives you any idea at all, which is not very helpful. But anyways, they taught you have kidney stone dance, they constant moving. So kidney stone dance, severe CVA pain or your back flank pain. You can also have shock-like symptoms. So pale, clammy, rapid, low heart rate, things of that nature, fever, chills, all depends on the severity of it. You may have UTI symptoms, pain, and the pain can be ranging from dull to very sharp, and that actually has a lot to do with identifying your kidney stones. So these are some of the manifestations of nephrolithiasis. And nausea, vomiting. Nausea, vomiting is the other one. So, and nausea and vomiting relates to pain, not anything else. And it can't be so. So kidney stone dance. All right. So they have a really hard time being still, and that's just because they're trying to relieve the pressure or the pain related to that stone. Now, stones can be really small, or they can be broken up into these horrible, what they call stag horn. They pretty much look like antlers, and they take over entire kidneys. It's horrible. So there's no way you're going to pass something like that, obviously. All right, and these are like really jagged and sharp. So that's the manifestations of it. The test to be able to identify this is generally going to be your CT, and they call it KUB, which is kidney, ureter, bladder. You can always just add things on here. So I could be kidney, ureter, bladder, urethra. But anyways, kidney, ureter, bladder is what they usually order for this. And then a CT scan. Obviously, you're going to do a UA because that's going to probably, or at least hopefully, identify what would be the main cause of the stone. And that's one of the biggest things. You're going to see high buns in that UA, maybe hematuria, all depending on the stone. Red blood cells, hematuria, but CAS specifically, and white blood cells. So those are some of the things you might see in the UA. Alright, so there's 5 different types of stones, and they range, they're calcium phosphate, uric acid, I'm looking at this, there we go. Uric acid, calcium phosphate, one's produced strictly from just urinary tract infections, like, and again, that's going to be more prevalent in women, because it's got that UTI factor. So the 5 types is calcium, oxalate, alright, and this is going to be caused by a high, well, you're going to see high calcium, and calcium phosphate, and this is mixed. This is mixed stones formation, and this is going to have alkaline urine. So again, alkaline urine is not going to allow for the breakdown of some of those specifically calcium. All right, and strivite, I believe is how you say that. But strivite, that's going to be in UTIs, and uric acid, and cysteine. Alright, so let's go through these really quick. I'm not going to get too deep into it, but so calcium oxalate, that's going to come from that green roughage, the green roughage, the chocolate, things of that nature. You're going to see a high calcium level. Now, any time that you want to make the urine alkaline, you're going to use potassium. That's on the screen. Yeah, potassium citrate. Maybe I spelled that right. Potassium. Okay, yeah. So potassium citrate. Oh, citrate. It is a name. Citrate. All right. So potassium citrate is gonna take your urine from acidic to alkaline. All right. So it's gonna make the urine alkaline. That being said, you would use these 90% of the time, except for here and here. And the reason why you're not going to use it on a UTI is because a UTI is obviously an infection, and you obviously need antibiotics for it, right? So it would not make sense to do that. Of course, you're going to treat the pain in all of these cases, but you're going to need antibiotics for your strivite, which is caused by UTIs, again, predominantly in women. This one has alkaline urine, so you would not make more alkaline urine. That doesn't make sense. You also need to figure out what this is made out of right here. So that's going to be another issue you need to address. But potassium citrate could be used here because this is caused by acidic urine. It could be, obviously, uric acid is going to be caused by acid or acidic environment, specifically gout. But when you think gout, you think uric acid. Cysteine is actually where cysteine is not being absorbed in the GI system. And this has to do with a genetic factor. But you're going to use something to try and prevent cysteine formation or crystallization, and you're going to use prophylactics here. So those are the ones that you're going to use there. All right, so calcium oxalate, again, high calcium, low sodium. You're also going to use diuretics here. So you want to use your thiazide, strong diuretic. Calcium phosphate, that's that mixed stone. And really we need to figure out the underlying cause and figure out what these stones are made out of so we can properly treat it. Because if it's a mixture of different ones, we need to figure out which one it is before we start giving somebody something. And obviously for your strivite, you're going to use antibiotics. Uric acid, again, it's acidic urine and gout. So we want to try and make it a little bit more alkaline and try and treat those gout symptoms. So you'll see that potassium citrate again. And cysteine, you're going to use a lot of hydration as well. And you want to give that potassium citrate here as well. So that's going to be your acid. But you're going to use some prophylactics here, penicillin specifically, to try and prevent that crystallization. So those are your 5 types of kidney stones: calcium oxalate, calcium phosphate, strivite, which is your UTI, uric acid, and cysteine. Okay. Bottom line, we need to be able to figure out what it is. All of them you're going to want to hydrate, but not ever force hydrate. That's because obviously they're not hydrated enough. But force hydrating is only going to increase their pain at that point. You want to increase hydration, but not to the point where you're forcing hydration. Really, our goal is 2 liters of output a day in urine. So that's the goal. Enough. Usually about 3 liters in and 2 liters out. But anyways, that will be the goal. Okay, so the treatment besides the ones that I've already mentioned, and I'm going to spell that for you, Tamsusin. These are muscle relaxants. Muscle relaxants, because remember the bladder is a muscle, and if we're going to try and pass that stone, if it's 4 millimeters or less, we have a good probability of passing that stone. And if we're going to pass that stone, we can relax the muscles and allow the stone to pass a little bit more freely. The bottom line, increase hydration is going to be important. Decrease sodium intake, and education is going to be your star here, because we really want to try and prevent future stone formations, because usually these are reoccurring. So we need to talk about sedentary lifestyle. We need to talk about proper hydration. We need to talk about if it's related to UTIs, hygiene, and all the things that you would use as far as your patient teaching as far as UTIs go. All right. There is sometimes where you're going to need to have surgery, and in surgery we're going to perform surgery if it's a large stone, or if it's related to systemic infection, because if it's a systemic infection, maybe the UTI spread to such a point where it's got upper and lower and all types of other stuff. Or if they only have one kidney, we're not going to put that kidney at risk. So if they only have one kidney, we're going to have surgery there as well. Too large. Oh, or if the symptoms are very severe and not going away, then we're going to have we might have surgery there as well. So too large. If it's a systemic infection, if you only have one kidney and your symptoms are severe. If at this point you've determined from your CT scan that the actual stone's in the bladder, but it's not going to be able to make it through the urethra, then you can do a laser treatment where you're breaking up the stone. Of course, the problem will be that you're going to have to still have small chunks of stone that are going through the urethra, and that's going to create pain issues. But you can do that. That's called lip. Let's make sure I spell this right. Laser lip. All right. So doing the laser lithotripsy for the urinary tract, and that's gonna cut down that maybe a large stone to many small stone pieces, so that the person can actually pass the stones. And of course, as a nurse, you want to make sure that they're not going to have any bleeding, that they haven't had any punctures, treat for pain, make sure they're hydrating, things of that nature. Again, don't force fluids. once you figure out that stone formation, and it's going to be important to get that stone from whether you do the surgery or the patient tries to pass the stone, you really want to figure out what's in that stone so that you can further the education, maybe it's a reduction in purines or a reduction in calcium or a UTI. So we need to know the stone formation. That's going to be important as far as further prevention. All right, so that pretty much sums up nephrolithiasis. That's a mouthful. All right, and we're going to go into nephrosclerosis. Sclerosis is just a hardening of vascular capillaries, vessels. So sclerosis by name is the hardening of a structure. All right, so sclerosis. Basically, what we're talking about here is the hardening of the capillaries that wrap around your nephrons. And when that happens, we're going to have several factors. So a hardening of capillaries around your nephron. And if you can remember back to your nephron, the capillaries wrap all the way around down the tubules throughout the entire capsule. So there's a lot of capillaries that can be blocked there. But when we have a hardening of capillaries, a lot of times that's caused by hypertension. Remember, capillaries are made out of muscles. So when we have hypertension for prolonged periods, a lot of times you'll get a hardening of the capillaries. This also happens with age. So age is, a huge factor here. And as we get older, we lose elasticity. The hardening of the capillaries is going to create ischium or decreased blood flow with pain, which eventually will lead to necrosis. All right, when we have necrosis of one of our kidneys, we're going to have decreased glomerular filtration rates. You're also going to have, oops, sorry about that, almost knocked this over. All right, so you're going to have decreased GFR rate. You're going to have an increase in pressure. You're going to probably get back UAs where you have the, the blood and the proteins and all that other jazzy stuff that you're not supposed to have in your urine. All right. And our treatment for this is going to be aggressive treatment of our high blood pressure, because this is the only thing that's going to help at that point. All right, so we can't unharden the capillaries necessarily. I mean, you can give a muscle relaxant, but that's about it. But we need aggressive treatment for that blood pressure so that we can try and prevent any further damage and try and get back the function in the kidneys. All right, so that is nephrosclerosis. Again, sclerosis is just hardening of your, really by definition, just hardening. But and when we talk about the body, we're talking about hardening of our vascular spaces, and that means that we're going to have decreased filtration and eventually necrosis if it's not treated. So aggressive treatment for your blood pressure there. All right, and your other one is, now this is kind of crazy, polycystic, oh, I have it written up there, oh well, polycystic kidney disease. So this is, believe it or not, the most common cause of life-threatening disease in the world, which I thought was pretty crazy. So this is the most life-threatening disease in the world, or most prevalent at least. And it's a genetic issue. And basically, you'll have a kidney, and it's just jammed packed full of these cysts. And as these cysts get larger and larger, the kidney expands in size, and I mean, these cysts are everywhere. They also go into the liver. For the obvious reason, this is going to cause huge issues. All right, you're going to see blood in the urine from the rupture of these cysts. You're going to see decreased filtration, and unfortunately, people generally don't notice that they have it until these cysts have gotten pretty large. In children, so there's recessive and there's dominant. You can remember back to genes, but recessive is usually in children, or it's found when you're younger. Dominance happens usually about 30 plus. So, and again, it is genetic. The your manifestations of this is going to be high blood pressure. Again, like I said, blood in the urine because of the ruptures of the cyst, UTIs, chronic pain, and again, it affects the liver. There is really no treatment for this, unfortunately, because it is a genetic disease, but we can try and treat the pain, and of course, we're going to try and get a transplant. Usually before you have a transplant, you have dialysis, so that's another option at least to try and get on that transplant list. But, so polycystic kidney disease, completely genetic, resistant, dominant in adults, recessive in children. Result is high blood pressure, UTIs, chronic pain, issues with your liver. There's no treatment, but we're looking for dialysis, pain therapy, and eventually transplant. The test itself is going to be a DNA test to positively identify PKD, but unfortunately there's really not a treatment for that. Alright, so that is nephrolithiasis, nephrolithiasis, and polycystic kidney disease, okay?